Okay, want to welcome everybody to this week's happy hour. Glad everybody could join. As is always the case, if you have any questions at all, I'm going to kind of mind the chat, so I'll keep my eye on it periodically and can address any questions. But if I don't get around to answering your question, please feel free to submit them to uh, uh, education@sagesdx.com, or you can email me directly, tdavis@sagesdx.com. And I never mind anybody texting me or calling me. My cell is 210-416-4815. And I think April is typing those into the chat. So I thought we'd do something a little bit different this week. The focus will be a little bit different. I know a lot of you are probably preparing for the core exam, and some of you who are watching may be preparing for the applied exam. For the core exam, most of it's going to be, the best diagnosis is AX, or you'll get some questions about laboratory techniques, or possibly some basic science related to basement membrane zone. There may be a few second order questions and third order questions. I think for definitely that's going to be the focus in the applied exam. I mean, by that point, they've already tested your ability to recognize slides and knowledge. So it's called the applied exam for a reason. They want to know what you're going to do with that information. So I think you can expect all of your histology, all of your slide to be embedded in case scenarios. So you'll, look at some clinical photos, and they might ask you about differential, and then ask you what you want to do. You'd say biopsy, and then, they'll probably show you the histology, but the question probably will not be, what is this? It'll be the next lab test you should order is X, or the treatment would be Y. So I don't think there will be very much direct. So when you're studying for the applied exam, I would go through a textbook of dermatopathology and focus on those entities where that are amenable to embedding in a clinical scenario. Sebaceous tumors, or disorders associated with metabolic abnormalities, or possibly paraneoplastic conditions. So hopefully this session today will get you thinking along those lines. So we'll first look at the case and kind of talk about the diagnosis, maybe in a couple of instances comment on differential, and then we'll go to the questions to answer those. So hopefully you'll find it helpful. Okay, our first slide is a shave biopsy, and this was from the trunk. We can see within the dermis a nodular infiltrate. The epidermis may be a little bit thinned here. And as we move into higher power, we can see that clearly there are some dark staining cells in the infiltrate with small round dark nuclei. These are likely lymphocytes, maybe a few granulocytes, but many of the cells have kind of abundant clear staining cytoplasm. These cells are larger, and if we move into higher power, we can see that these cells are actually histiocytes. They have round to oval nuclei that are larger than those of the small dark lymphocytes in the infiltrate. And these histiocytes are filled with lipid. And so they're foam cells. And so we've got a xanthomatous process here. Throughout the dermis, you can see a sprinkling of lymphocytes. And really what catches your eye, what should catch your eye, is the presence of some of this clear, kind of feathery, pale to slightly basophilic material present extracellularly. And this is extracellular lipid. And the combination of these foam cells with extracellular lipid is diagnostic of an eruptive xanthoma. So we have an eruptive xanthoma here. The one type of xanthoma that will kind of throw people off that is clearly the key differential diagnostic consideration is a xanthelasma. And that's because the foam cells in xanthelasma, like most xanthomas, look very similar, and they can be clustered together like those that you see in an eruptive xanthoma. What distinguishes the entities is the following. One, xanthelasma occurs almost exclusively on the eyelid. And so typically you'll see an epidermis that's quite thin, certainly will not have a cornified layer that's kind of thickened like this. You tend to see a lot of vellus hair follicles, and frequently you'll see skeletal muscle in the dermis because the muscles of mimetic expression do attach to the dermis in eyelid skin and then much of the face. So eyelid scan, number one. Number two, xanthelasma will never exhibit extracellular lipid. And number three, eruptive xanthomas, as a rule, are much more inflammatory lesions. Very early in an eruptive xanthoma, one will see a fair number of neutrophils within the infiltrate. And clinically, the correlate of this, when you look at these lesions, especially early on, they tend to occur in crops that are have an abrupt onset. And there frequently is a surrounding rim of erythema at the periphery of the lesions. So there's much more inflammation and extracellular lipid in an eruptive xanthoma than in xanthelasma. Well, I think we've talked enough about that. Let's go ahead and go to our first question. Knowing that this is an eruptive xanthoma, the question was, lesions such as these may be seen in the setting of, and the correct answer, of course, is E, all of the above, because in all of the conditions listed here, one may see eruptive xanthomas. Another question they could ask you here would be, in a patient with lesions such as these, the best laboratory test to offer or to order would be, and of course you'd want to get a serum lipid profile because these patients almost always have elevated triglycerides. So we'll go ahead and move on to our next case, case number 2. And here you can see, I'm going to tilt the slide, that we've got a large, excisional biopsy specimen here. There are some folds present in the tissue, which sometimes happens with big pieces of tissue. And the epidermis is a little bit thinned. This was actually from the trunk. The dermis is relatively thick. And at lower power in both of these pieces of tissue, we can see that we have kind of a dense diffuse infiltrate, really involving much of the reticular dermis. There's really no intervening, uninvolved dermis in these sections. And the infiltrate's kind of bottom heavy. If we look at the upper reticular dermis, with the exception of this particular area over at the side, we can see it's kind of relatively uninvolved. And there is extension, again, of the infiltrate into the subcutaneous tissue. Well, what do we have here? Well, I think as we move into higher power, you can see that we've got these broad kind of intersecting zones of collagen degeneration. Some of them are a little bit X-shaped. And if we look at the collagen in this area, we can see that the fibers are a little bit smudgy. The collagen is clearly degenerating, a process that's sometimes referred to as necrobiosis. And there's a lot of neutrophilic nuclear debris here within the zones of degenerated collagen. These are encased at their periphery by collections of epithelioid histiocytes. And some of these epithelioid histiocytes have the appearance of foreign body giant cells. And you can see they're really large and kind of bizarre looking. They've got a huge number of nuclei in their cytoplasm. There's an accompanying infiltrate of lymphocytes and histiocytes here. And then in a few areas out at the periphery, hopefully I'll be able to find it, there were no cholesterol clefts, but there were clearly some foam cells here. So in this particular entity, the degree of lipidization can kind of vary. And again, note that there's no intervening areas of normal collagen. And this appearance should really make you think of necrobiotic xanthogranuloma. The key differential, of course, is Necrobiosis lipoidica. In Necrobiosis lipoidica, the infiltrate is usually not quite as robust. In addition, the zones of collagen degeneration tend to be more horizontally layered and rather than the X-shaped zones. And when you look at the zones of necrobiosis, they're cleaner. You usually don't see as much neutrophilic nuclear debris, and you don't have as many bizarre multinucleated giant cells. That being said, there can be some overlap here. Okay, so with that in mind, let's go ahead and go to our question. And our question is, in patients with lesions such as this, the most appropriate laboratory test would be, and of course the answer is B, an SPEP with immunofixation. Almost all of these patients do have a monoclonal IgG kappa paraproteinemia. And so you'd want to make sure that you checked an SPEP with immunofixation in these patients. Okay, moving on to slide number 3. Slide number 3, we have a punch biopsy. Let me just tilt the slide a little. And this punch biopsy was obtained from the upper trunk near the neck. And one can see the epidermis is largely uninvolved. And within the upper reticular dermis, we can see that there's an infiltrate. Clearly, it's a little more cellular in this area. And if we move in and take a look at the infiltrate, there are clearly some lymphocytes around the vessels, but we can see that most of these cells in this infiltrate are spindle-shaped, kind of delicate fibroblasts. And these are embedded in kind of a myxoid stroma and are kind of the mucins kind of pushing apart the collagen bundles. And this is a very characteristic appearance for lesions of Lichen myxedematosus, Scleromyxedema. Those conditions tend to run along a spectrum. Now, I think the one pitfall with this is that at first blush, a lot of people will think of granuloma annulare because the cells within the dermis are distributed in a very similar fashion. But in granuloma annulare, one has epithelioid histiocytes rather than spindle cell fibroblast. Again, these two conditions, Lichen myxedematosus and Scleromyxedema, run kind of along a spectrum. Of course, with Scleromyxedema, one gets more extensive involvement with lesions and hardening of the skin. Okay, and let's go ahead and move to our question. And we're asked, which of the following laboratory abnormalities is associated with this condition? And of course, the correct answer is an IgG lambda paraproteinemia, in contrast to the IgG kappa paraproteinemia, which we talked about being associated with necrobiotic xanthogranuloma. I will point out that there is a very, very small subset of patients with Lichen myxedematosus or Scleromyxedema who have subclinical hypothyroidism, and they may have an elevated TSH. But again, the majority of patients with Scleromyxedema have an IgG lambda paraproteinemia, and a fairly high percentage of patients with the less extensive form of the disease, Lichen myxedematosus or papillomammalosis, also will have an IgG lambda paraproteinemia. Okay, let's go ahead and move on to our next case, case number 4. And what we have here is a punch biopsy from the trunk. And I think, what really should grab your eye here is the marked thickness of the dermis. I mean, you would do this punch biopsy, the dermis just keeps on going and going and going. There's only a small amount of subcutaneous tissue here. And so we've got a squared off biopsy. We don't have much inflammation here, and it's markedly thickened. And what is it thickened by? Well, it's thickened by, an increased number of collagen bundles. They're a little bit haphazardly arrayed, and they're separated from one another by fenestrations, which in this case the fenestrations are occupied by an increased amount of mucin. And this, of course, is a very characteristic appearance for scleredema. This is the most mucin I think I've ever seen in a biopsy of scleredema. Sometimes it can be much more subtle. And of course, the differential always is, on a board exam, is always going to include morphea, which has the thickened collagen bundles, but they're compressed. They're not separated by fenestrations, and they'll bind down the eccrine glands. And sometimes there's a little bit more inflammation. Okay, and so the question in this instance was, which of the following statements regarding this correction is this condition? Should read condition, not correction, is correct. And the answer is E, all of the above. This is a condition that commonly occurs on the upper back, frequently in patients with insulin-dependent diabetes. Of course, there's a subset that can occur in patients suddenly after strep infections. It can be associated with a monoclonal gammopathy. And the patients may actually develop, we don't think of it very often, but systemic symptoms with involvement of cardiac, ocular, and skeletal muscles. So they may have, an abnormal EKG. Okay. Let's go ahead and move on to our next case. And we're going to move on to a few adnexal neoplasms that sometimes have significance. And in this case, we have a shade biopsy. And we're going to see it's transecting the upper dermis and emanating from the undersurface of the epidermis, arising from the epidermis and in part from follicular epithelium. We have a fairly well circumscribed epithelial neoplasm with kind of a benign silhouette. At the periphery of the neoplasm, these aggregates are composed of somewhat basaloid appearing cells. But if we look at the central portion, we can see that these cells look a little more like keratinocytes from follicular epithelium. They're larger, like those in the mid-spinous layer. And most of these have vacuolated or clear staining glycogenated cytoplasm, giving it this clear staining color. The nuclei are uniform. There's not much pleomorphism. And if we look at the periphery of these aggregates, we can see that many of the cells have kind of a high cuboidal to columnar appearance, and they're kind of situated on a basal lamina here. And of course, these features, this constellation of features, is diagnostic of a trichilemmoma. One of the epithelial neoplasms that I think can mimic a trichilemmoma, and sometimes it can be hard if one has a partial biopsy, is an IFK, an inverted follicular keratosis, also a benign adnexal neoplasm derived from follicular epithelium. IFKs tend to have a little different architecture. They tend to be kind of exoendophytic. And of course, the histologic hallmark of an IFK is the squamous heady, the whorls of partially keratinized epithelial cells. So anyway, this is a trichilemmoma. And let's go ahead and move on to our question. Patients with multiple facial lesions such as this, and when you do see a question like this, obviously multi-trichillemmomas are associated with the Cowden syndrome, which of course is an autosomal dominant condition characterized by PTEN mutations, have an increased incidence of all of the following conditions except, and of course the answer here is D, spontaneous pneumothorax, which we tend to associate with the Berthold-Dubé syndrome. So anyway, this was Cowden syndrome. Now, fortunately, when they on your board exam, I was a little mean here. I put a lot of except or false. The questions are usually straightforward and in the affirmative. So they won't give you questions like all of the following except or which of the following conditions is incorrect. They encourage people who are writing these tests to write them in the affirmative. So the wording of these is harder than what you can expect on a standard exam. Okay, we'll go ahead and move on to slide number 6. And slide number 6 was a very small biopsy. We'll go ahead and tilt it, and we're going to have to move into high power to say much about this. This was a punch biopsy. It was from the head and neck. You get a clue for that location by the presence of these large sebaceous glands and an increased number of follicular units. These are vellus hair follicles. And the area of interest, of course, is in the upper reticular dermis on the left half of the slide. And you can see we've got this kind of orb-shaped proliferation here. And this is kind of a composite neoplasm, if you will. It's got an epithelial component, which consists of these kind of thin anastomosing strands of uniform follicular epithelium. And they're located at the periphery of and kind of extending into a mesenchymal proliferation of uniform spindled cells embedded in kind of a myxomatous stroma. And of course, this constellation of features is diagnostic of a fibrofolliculoma. And the histology of fibrofolliculomas is somewhat variable. Some of the lesions can be quite large, some can be quite small. And it's generally accepted now that the fibrofolliculoma and trichodiscomas are part of the same neoplasm. It used to be that the mesenchymal portion of this neoplasm was felt to be separate, a trichodiscoma, and the epithelial component of fibrofolliculoma. I think most people have now accepted the fact that the two are one tumor, and most people will now talk about fibrofolliculomas. And of course, depending upon where you section the tumor, you're going to get more epithelium or more mesenchymal component. Anyway, that's kind of my spill on fibrofolliculomas. So let's go ahead and go to our question. And we were asked, patients with multiple lesions such as this, and again, you see multiple fibrofolliculomas, you want to think about the Berthold-Dubé syndrome. Again, this is another autosomal dominant condition caused by mutations in the folliculin gene. And patients with multiple lesions such as this are at risk for renal oncocytomas. A, that's correct. B, spontaneous pneumothorax, that's correct. They get multiple pulmonary cysts. C, chromophobe renal carcinoma, that's also correct. And sometimes the renal tumors, the renal cancers, can be hybrid as well. They'll show some areas that look like oncocytoma and some look more like a chromophobe renal carcinoma. So the first three are correct. These patients are not at risk for hepatic failure, so that's incorrect. And so the correct answer in this case is E, 3 of the above, because A, B, and C are correct. And again, they aren't going to give you questions worded like this on the board exam, but I wanted to make it a little bit tougher because then when you take it, it's going to be easier. Okay, let's go ahead and move on to our next case. Again, we're still kind of in the realm of adnexal tumors. And in this particular biopsy specimen, we've got an epithelial neoplasm confined to the dermis. This was actually from an extremity. You can see there's a fair amount of fat here. And we have a very well circumscribed neoplasm in the dermis with kind of a benign silhouette here. And it's kind of got a little bit of a cystic configuration. And if we look at the periphery of this lesion, we can see we have an aggregates of epithelial cells. Most of them have kind of a basaloid or germinative appearance. They have round oval nuclei and not much in the way of cytoplasm. There's a little nuclear pleomorphism, but most of them have an even chromatin pattern, and there aren't a whole lot of mitotic figures or zones of necrosis that are obvious. But what we do see in the central portion of these aggregates are clusters of cells with a mature sebaceous phenotype. We have these cells that are laden with lipid vacuoles, and you can see in areas such as this that these lipid vacuoles are kind of compressing the nucleus, giving it kind of a scalloped border. And so we've got a kind of a more primitive sebaceous neoplasm here with a cystic quality. And then in other areas, we've got a lot of mature sebacites. So when you see any sebaceous neoplasm, you obviously want to think about the possibility of Torrey syndrome in your patient. And particularly cystic sebaceous tumors such as this have been reported in the literature to occur more frequently in patients with a Torrey syndrome. So definitely if you see a cystic sebaceous tumor, you want to think about the possibility of Torrey syndrome. Excuse me, Torrey syndrome. So let's go ahead and move on to our question. Which of the following statements regarding the syndrome associated with lesions such as this is incorrect? I had to ask a negative question. And again, we're talking about the Torrey syndrome here, Muir-Torrey syndrome, which is really an allelic variant of the Lynch or hereditary non-polyposis colon syndrome. Well, let's consider these. A, it's inherited as an autosomal recessive condition. Well, that's our false statement. It's inherited as an autosomal dominant condition, which I'm sure most of you knew. And the other statements are correct. Of course, it's associated with the mutations in the mismatched repair genes, including MLH1, MSH2, MSH6, and at times PMS2. Patients do have an increased risk of colorectal GU malignancies, breast cancer, and keratoid xanthomas. So those are all correct statements. Okay, and I'm sure on the applied exam you're going to get something about Muir-Torrey syndrome, and when you want to do germline testing and genetic counseling, tumors that the patients are at risk for. Okay, let's go ahead and move on to our next case. Okay, case number 8. And this was an interesting lesion. We have a shade biopsy here, bisected shade biopsy. I think we'll focus on this top piece. Well, actually, let's look at the bottom piece first. These sections were cut a little thick, and the slide was darkly stained, and I apologize for that. But that's sometimes what we have to deal with. And if we move in to higher power, we can see, well, I tell you what, let's look over at this area first, because what we've got here are nest cords and strands of melanocytes. I think I'll actually go up to that top piece because I think we can see it a little better over here. So at the periphery of the lesion on both edges, you can see we've got a population of fairly uniform melanocytes here. Some of them are multinucleated, but they're cords and strands, and they do show evidence of maturation with depth. And again, the more banal appearing melanocytes were on both sides of the specimen. But centrally, we've got a population of much more atypical melanocytes. And these melanocytes have a very epithelioid appearance. They have abundant pink to more pale staining cytoplasm. Some of the cells are multinucleated. The nuclei are pleomorphic with prominent nucleoli. But if we take a look, and there's no maturation here, but if we take a look, there's no mitotic figures. They're just non-present here. And these are very epithelioid melanocytes, similar to what you see in a Spitz nevus. And so you might consider here some type of combined melanocytic nevus with banal and a Spitz component. And when you see and epithelioid proliferation of melanocytes plop down in the middle of an otherwise banal appearing lesion such as this, and there's no significant atypia, you want to think about the possibility of a BAP1 inactivated melanocytic tumor. And we would confirm that, of course, with a BAP1 immunohistochemical stain, which would show absence of staining in these more atypical melanocytes and strong nuclear staining in the banal appearing melanocytes, and indeed in every other cell here in the follicular keratinocytes and the epidermal keratinocytes. They would all express or be stained with the BAP1 immunostain. So, people have termed these tumors BAPomas, but it's really kind of the reverse. They're BAP deficient tumors. And so I think people in this particular instance, or, now will refer to these as either BAP1 inactivated melanocytic nevi or BAP1 inactivated melanocytic melanomas. And if you're not too sure of the biological behavior, you just call it a BAP1 inactivated melanocytic tumor. Well, with that in mind, then the question is, patients with lesions such as this should be asked about a family history of, and of course the correct answer is all of the above. Now clearly, most of the BAP1 inactivated melanocytic nevi that we see are solitary, and most of them are the result of sporadic rather than germline mutations. But patients with germline mutations obviously are at risk for the BAP1 tumor predisposition syndrome. So, the question is, when do you refer a patient for genetic counseling and possible consideration for germline testing? And the recommendations now generally are, if a patient has 2 or more BAP1 inactivated melanocytic tumors and or a family history of uveal melanoma and mesothelioma, then those patients should be, regardless of age, should be referred to a geneticist for counseling and germline testing. So I would definitely review the BAP1 lesions and the BAP1 tumor predisposition syndrome, because I can almost guarantee you on the applied exam, you're going to get some questions about this particular entity. It's kind of a hot topic. Okay, let's go ahead and move on to our next case, case number 9. And what we have is a bisected punch biopsy. And this was, again, up near the head and neck. You can see we've got a large number of sebaceous glands and hair follicles. And we've got an infiltrate within the dermis. It's kind of filling in the right half of the specimen, the upper reticular dermis. And, because it's partially sampled, we can't really comment too much on the architecture. But in the area where we can see the edge, it doesn't appear to have much of an infiltrative border. Let's go ahead and look at the cells comprising this proliferation. And as we move to higher power, we can see that we've got these sweeping kind of intersecting fascicles of spindle cells. Some are cut longitudinally, some are cut in cross-section. And if we look at the cells cut in cross-section, we can see some perinuclear vacuoles or glycogen snacks. And the cells that are cut more longitudinally do have kind of large blunt-ended or cigar-shaped nuclei. So the fascicular arrangement, the morphology of the spindle-shaped nuclei and the perinuclear vacuoles should all lead us to strongly favor a smooth muscle tumor in this case. And this is indeed a leiomyoma. Now, again, we do have gauges here that we can use for identification of histogenesis. So if we go over here, we've got just a couple of erector pili muscles associated with the follicular unit. And if we look at the nuclei comprising the erector pili muscle, you can see these are virtually identical to the nuclei comprising the tumor cells. So, if you're kind of struggling whether something's neural or smooth muscle. Back off, see if you can identify a normal structure that you can use as a gauge or benchmark to help you with histogenesis. So anyway, we could confirm this, of course, with SMA or Desmond staining. We really don't need to here. You should be able to recognize a leiomyoma just on the basis of architecture and cytology. Okay, let's go ahead and move on to our question. Well, patients with multiple cutaneous lesions, multiple cutaneous leiomyomas, you should be wondering, of course, about the possibility of Reed syndrome. Reed syndrome, of course, can be associated with multiple cutaneous and uterine leiomyomas, and it's an autosomal dominant condition caused by a germline mutation in the fumarate hydratase gene. And we're asked here, patients with lesions such as this have an increased incidence of what type of cancer? And the answer, of course, is D, renal cell carcinoma, and particularly type 2 papillary renal cell carcinoma. Okay, we'll go ahead and move on to slide 10. Okay, and the last couple of cases are kind of cousins, kind of closely related non-Langerhans cell histiocytic conditions. And in slide 10, we have a trisected timid punch biopsy here. This slide's a little on the blue side. The one slide that we looked was a little on the red side, the BAP1 inactivated melanocytic tumor. We can see that the epidermis here is kind of thinned and that this infiltrate is partially sampled. It's filling the dermis. As we move to higher power, you can see that there are kind of light and dark staining areas. And again, the darker staining areas, we've got a lot of these round nuclei that are dark, highly suggestive of lymphoid cells. And then we've got a population of very large histiocytes. And these histiocytes have a very distinct two-tone cytoplasm. They've got that kind of dusty rose or ground glass center, and then the more pale staining periphery. And some of these are present in lacunae or spaces. Some of the cells are multinucleated. And if you take a look, you can see there's a sprinkling of neutrophils and eosinophils present within the dermis. Now, notably absent here are a couple of things. There are no two-tone giant cells. There are two-tone giant cells, but not the two-tone giant cells with the wreath nuclei and lipid that should lead one to consider strongly a xanthogranuloma. And there's also an absence of foam cells in the infiltrating. Foam cells are readily found in xanthogranulomas, foamy histiocytes. So the correct diagnosis in this case is a reticulohistiocytic granuloma. So let's go ahead and go to our question here. Which of the following statements regarding this condition is incorrect? And of course, the answer was A, the lesions are always multiple. In actuality, we see solitary reticulohistiocytic granulomas with a much greater frequency than multiple lesions. When they are multiple, however, they can be associated with systemic findings, and I'm sure most of you know that multicentric reticulohistiocytosis, the condition where the patients have multiple reticulohistiocytic granulomas, may be associated with a deforming arthritis, and it can produce that classic telescope deformity on X-ray. And I remember when I did take my derm boards, they actually showed us a picture of the coral beading and an X-ray and a histology slide, and then ask about what the diagnosis was. There may be an associated internal malignancy too, in up to 10% of the cases. And again, that coral beading around the nail folds is very distinctive. Okay, moving into the home stretch here, our last slide. And there were actually two specimens here, which of course was what the question was about. We'll go ahead and start with the lesion on the left. And it's a little bit of a fragmented, bisected shade biopsy. I'm going to tilt the slide, and then we'll take a look at this one and go back and look at the second larger specimen. Okay, bear with me here. So we've got a shade biopsy here The epidermis is quite thin. And on first blush, this looks very much like the reticulohistiocytic granuloma slide we looked at. We've got an infiltrate present in the dermis, and we've kind of got light and dark staining areas. But when we go in and take a look at the infiltrate, we notice a couple of differences. One, we've got a lot of just beautiful Teuton giant cells here with the kind of pink center, the wreath of nuclei, and then lipid out at the periphery. And these are readily present throughout the infiltrate. Two, notice that we've got these foamy histiocytes throughout the lesion. You're not going to see those in a reticulohistiocytic granuloma. And then three, we've got kind of this brisk inflammatory infiltrate, which we can get in both with lymphocytes and eosinophils. But this histology is very characteristic, of course, of a xanthogranuloma. And these are non-Langerhans cell forms of histiocytosis that we can see both in adults and children. So let's go ahead and look at lesion number 2. Excuse me. Okay, and let me flip the slide again. And lesion number 2, over on the right side, was a dome-shaped papule. And if we move to the core of this papule, this pedunculated papule, we can see we've got a proliferation of pretty delicate spindle cells. You know, and compared to the spindle cells that comprise the Leiomyoma we looked at, these are very delicate with tapered ends, and you know, we've got a few scattered mast cells here as well. These are evenly spaced, and this is, of course, a very characteristic appearance for a neurofibroma. So we've got JXG, neurofibroma. And our question is, patients who present with both of these lesions are at increased risk for, and the correct answer is C, juvenile CML. And that's an association that you want to be aware of. If you have patients, if we were talking just about xanthogranulomas, if you've got a kid with multiple xanthogranulomas, especially on the head or neck, you want to make sure you send them for ocular screening because they're at higher risk for acute closed angle glaucoma due to bleeding into these in the ear. So hopefully you guys found this group of questions helpful. Again, it was as much to prompt you into thinking about second, third order questions as you're preparing for the applied exam. And again, no questions. If anybody has any, please feel free to send them to me. Thanks for joining. Have a good evening.